Patients who are consistently short of breath would greatly benefit from prone positioning because their work of breathing is reduced as the cardiac and abdominal organs reduce their pressure on the lungs. This will save vital energy the patient needs in recovery. Indications include patients with ARDS and life-threatening refractory hypoxemia, posterior burn wounds and skin flaps, pulmonary artery occlusion pressures greater than 18 millimeters of mercury without ventricular failure, and bilateral infiltrates anteriorly and posteriorly on the chest X-ray. Not everyone with ARDS needs to be placed in the prone position. Contraindications include patients with increased intracranial pressure or head trauma, asthma, second or third trimester pregnancies, recent anterior surgeries of any kind, increased abdominal pressure, open wounds, or flail chest, C-spine precautions, injuries, or abnormalities, extreme obesity, hemodynamic instability, history of poor toleration of prone positioning, kyphoscoliosis, recent cardiac arrest, and any new tracheostomy. Before turning the patient, there are multiple considerations to factor in, namely, pressure risk and provisions to prevent damage, eye and oral care accessibility, closed suction availability, central and arterial IV access points patency, wound dressings, airway securement, chest X-rays scheduled ahead of time for new positioning, adequate sedation and pain relief, adequate chest drainage, removal and placement after positioning of EKG lead electrodes, and not disconnecting the patient from the ventilator. The actual procedure of placing a patient in the prone position always involves these considerations actively worked out for our patient. We want to be sure to do them every time along with the bed assessment. We will first assemble our critical care team of practitioners. This will include experienced nurses, respiratory therapists, and any other needed personnel. We will provide padding and support for potential pressure sore areas. This will include the face, upper chest, pelvis, knees, and feet. Before actually turning the patient, we will be sure to position them appropriately, being careful not to disrupt IVs, bandages, the endotracheal tube, or chest drainage points. We will also not allow their limbs to flounder about. The respiratory therapist or most experienced nurse should lead the group and maintain the secured airway. Using several pillows, in this case 3, and a bottom fitted sheet, 2 nurses should position the patient near them at the edge of the bed. If the patient is to be rolled onto their side, their right arm should be placed under the right hip. When the endotracheal tube and IV lines are secure, the team can slowly roll the patient into these prone positionings. The patient can then be placed in a swimmer's pose. The head should be turned towards the ventilator, never face down. Ensure the abdomen hangs between 2 pillow supports. Verify the correct position for periods of 6 to 16 hours a day for up to 10 days. Shortly after patients have been placed on the prone position, practitioners should see an improvement in arterial oxygenation via arterial blood gas analysis, SpO2, PF ratios, and hopefully improved lung mechanics that lead to fewer days on the ventilator. Nursing staff will also assess for pressure sore responsiveness, perform oral and eye care, complete a thorough body assessment including IV access and wound care. There are obvious known risk factors to being in the prone position for extended periods of time. Prone positioning can increase a patient's risk for skin breakdown over pressure points, causing facial edema and sheared skin and muscle damage of the thighs, hips, and buttocks. A suggestion to improve this risk is to use static air cushions under the hip-thigh regions to help prevent shear on the large leg muscles. A similar cushion for the chest will help provide immersion and protection to unused tissues due to weight bearing. Foot waffles can also help protect the heels, ankles, and toes. Specifically for the face and neck, 3 facial polyurethane foam mirrored positioner pillows and neck braces have been found to help reduce facial pressure points specifically. Consider even elevating the head of the bed to minimize facial edema. The ideal position leaves the head supported by the mattress alone without extending the neck. Let's quickly review a team approach to prone positioning. The goal is for the limbs to prevent extension and contraction of shoulders and elbows. There is limited studies and information available regarding patient repositioning to allow for passive movement, but patients in the ICU are typically repositioned every 2 to 4 hours, regardless, to prevent pressure sores on the body.